Hello, everyone, and welcome to our third annual, I guess at this point, Rehabilitation Connect Forum. I am Amy Byreth, and I have the distinct pleasure of introducing this session. I think that this is such an important opportunity for all of us who are intervention-minded individuals. I'm so thankful that all of you are here. I'm thankful for our panelists. I'm thankful to the ACIA for giving us this opportunity. I also want to thank Hearing First for sponsoring our Continue the Conversation that will happen following the session. I also want to thank our coordinating committee for this Rehab Connect Forum. The members of the committee this year were Yvette Sejas, Heather Grantham, Melissa Hall, Julie Jung, Elizabeth Rosenzweig, and then I kind of stood on the side and pretended to help a little. So thank you all very much for your contributions and for planning this amazing session that we have today. So without further ado, I would like to introduce our first two presenters. So Dr. John Oghalai serves as the Leon J. Tiber and David S. Albert Professor and Chair of the USC Caruso Department of Otolaryngology, Head and Neck Surgery. He leads a team of over 150 members that share his dedication to providing empathetic patient care, performing scientific research to discover better treatments for disease, and educating the next generation of clinicians and scientists. Prior to coming to USC in 2017, he held faculty positions at Baylor College of Medicine and Stanford University. Dr. Oghalai lives in Los Angeles with his wife, and during his free time, you can find him outdoors. He enjoys hiking, running, biking, and barbecuing. So as part of the Continue the Conversation that we're gonna have, he's bringing a grill so you can pick up your snacks to go along with your beverage. In addition to Dr. Oghalai, we have Dr. Holly Teagle. She is an associate professor of audiology at the University of Auckland and the clinical director at the Hearing House, which is the Cochlear Implant program for the northern part of New Zealand. Her career in audiology began in the early years of cochlear implant clinical trials, and she has provided patient care and contributed to cochlear implant research endeavors for over 35 years. Dr. Teagle has published many peer-reviewed articles and has presented nationally and internationally on topics related to pediatric audiology. She also enjoys being outside, but she didn't bring a grill. So, so thank you to everyone who is here. Thank you to our panel. Thank you to our presenters. And this is going to be a great session. Oh, I forgot one thing. There will be a lot of echo. There will be an opportunity for engagement and interactivity, so please make sure that you have your phones ready to be able to engage in the polls that are going to be presented, and make sure you have identified the microphone that is closest to you so that it's not just our presenters and panelists who are doing all of the talking. So now that I have made sure to clean up that housekeeping, Dr. Oghalai, you have the floor.
Thanks, Amy. It really is an honor to be asked to be part of this panel today. You know, I have to update that bio sketch because living in Los Angeles now for 6 years, about 9 months ago I turned vegan, so I haven't been grilling in a long time. Well, so what we thought, Holly and I had discussed, and we thought I'd start off by talking about a research paper that we recently published, and then we will have some case discussions, and it'll involve audience participation, a lot of question and answer, and additional panelists. So thank you. Oh yeah, the advance. Don't use the mouse, okay. I have no disclosures. Oh, you know, this meeting reminds me that I have not been to this meeting in probably 8 or 9 years now. And I forgot how good this meeting is, and it's gotten bigger, for sure. And to have the interaction with the audiologists and speech-language pathologists and psychologists is just amazing. And I miss that because it's a big part of what my clinical life used to be, because I started off working at Texas Children's Hospital at Baylor in Houston. And this was our cochlear implant team. at the time. And I had never really done pediatric implants before I took that job. I knew how to do a surgery, but I didn't understand anything about what pediatric implantation entailed. And so they taught that to me. And so the study that we're going to talk about today was really designed by this group of people right here. And I just kind of did the writing. Then I moved to Stanford. We have another couple of different, we had kind of an adult and pediatric cochlear implant teams over there. Again, I just learned more from, it's the interaction between all the different subspecialties that makes it so enjoyable. And then now at USC, we have this group. This is a partial picture of our group. But because I took over the department head, I don't really have time to do pediatric surgeries anymore. And so I mostly do adult implants, so I miss that. Well, of course, hearing is how a child naturally learns their language. And I'm kind of preaching to the choir here, in that an implant can give auditory information, but it isn't really going to give them language. So it can treat some physical problems. You know, the cochlea is what takes mechanical energy of sound in the air and converts it to electricity. Well, I mean, a microphone in a cochlear implant does the exact same thing. But getting a child to learn language is a whole different ballgame. And so who gets an implant? Usually children, you know, younger is obviously better. Severe hearing loss, hearing aids don't work. But really what's so important is the educational setting that the child is in. They need to be listening and speaking, and they need to be in a positive family environment. So yeah, this is one of my old patients from Texas, and I thought it's kind of suitable since we're here, and you can kind of see the little cochlear implant wire that's pointed to by the arrow. So when you think about an outcome for a child that's gotten a cochlear implant, I mean, there's a lot of different factors, right? So the child themselves is probably the biggest factor. You know, how old are they when we implant them? What are their cognitive skills? What's their personality, their attitude? Do they have any other issues? But the home environment, the family environment, the school, can they get any kind of extra therapy, or are they kind of limited by what's in their community? And so when we do a cochlear implant candidacy evaluation, we always want to think about what's the ideal outcome for this child, and it's going to be different for different children, right? And then, so basically, how do we define success? And of course, we want to get the parents to understand what an expectation of that success should be. And then we have to also plan, again, all preoperatively, well, what do we want this child to be getting in terms of therapy afterwards so we can obtain this level of success? And then finally, does our team as a whole think a cochlear implant's the right thing for this child and this family? And then we make our recommendation. Again, kind of preaching to the choir, but you know, it's hard to measure these behavioral responses in a child. And it's an iterative process. It's very labor intensive. The clinic managers, you know, they don't seem to understand how much time is required for these little kids compared to adults. The billers, they're unhappy with the volume differences between the adult and the pediatric audiological visits. And there's a lot of repeat follow-ups. And usually we like to get some kind of an annual speech and language eval, and if we can, a developmental exam from a psychologist. Okay, so, I mean, I think we all know that cochlear implantation is kind of basically considered the standard of care for a child with deafness. Doesn't mean it's the only option, but it's often what we consider the standard. Goal, of course, is to get the implant in by 12 months, hopefully younger. And if it's a child that's otherwise normal except for the hearing loss, there's a very good chance that they're going to end up in a general schooling programs and won't need major assistance later on in life. But the key is, of course, education. And so you can see on the left is Jody Heyman, who is our cochlear implant educator at Texas Children's. She's since retired, but you can see how she has a PowerPoint presentation. She would educate the child and the parents. This was all done, you know, preoperatively about what is going on. And then she might even do post-operative kind of therapy. And on the right, you can see Debbie Schrader, who's up here and teaching at our Come Read With Me class, where she's teaching communication skills to children, but also their parents sitting down there behind the children, so that these kind of things can happen at home after the class is over. It gets tough when a child has other issues, and they're not just deaf, but they have something else. They have other developmental impairments. And so the question that our cochlear implant group, this was back in Texas, we had was, well, can these child still benefit from an implant, even if they don't get all of the normal educational experiences because they just can't cognitively handle it? This started, well, I guess it was probably in the early 2000s. And we had a big children's hospital. We had a huge neonatal ICU. A lot of the children that were NICU graduates were surviving now, and they were deaf and they had other cognitive issues. And we didn't know what to do. And the standard at that time was to not perform a cochlear implant. And Texas Medicaid would fund it in some situations when we did all the proper documentation. And so there was a few situations where the parents wanted it. And so we did some, and we realized that, well, maybe some of these kids are actually benefiting in that they seemed happier, they kind of soothed, or when their mother talked, it kind of soothed them and they could stop crying. And so we wanted to try to study that. And I mean, you can imagine, it's really common to have, this is a very old slide, they don't really use the word mental retardation anymore, but that's what the term was back then. Now it's intellectual disability. But you can see the prevalence of these different developmental disorders. And so mental retardation is really high, but also hearing loss is quite high. And so there's a lot of patients that are going to have both. You could also call this developmental delays, children with special needs, deaf plus. We call this now early developmental impairment, or EDI. We've been through several different types of terms since we started this project. So the question we had was, should a deaf child with EDI, early developmental impairment, undergo cochlear implantation? And this is a child, they're too young to meet the definition for intellectual disability or mental retardation. So to get to, I forget what the exact ages you have to be, but you have to be above a certain age before you can actually meet official DSM-3 or DSM-4 criteria for that disorder. But they are on a track where they're probably going to end up into that category. And the issue, of course, with these types of children is it's difficult to assess whether the implant's helping them. They're also in a lot of other therapies, physical therapy and other kind of different therapies, and it would, putting in an implant kind of put them on a track for so many kind of also auditory verbal type therapies that it might detract from the other therapies that they need. So we really didn't know. Back then, there was a few centers like ours that were starting to do it. There's a lot of centers that would not implant a child with EDI. And some insurances would cover it, though those were kind of few and far between. So here's the known data from a lot of different groups about child development, so and cochlear implantation. So if you look on the x-axis at the bottom, it's age, and the y-axis is development or developmental age. And so if the child is not deaf and doesn't have developmental impairment, then as they get older, their developmental age will kind of rise equally. So if they're 1 year of age, chronologically, they'll be 1 year of age developmentally. If they're 2 years of age, chronologically, it'll be 2 years of age developmentally. But if you're deaf and you don't have developmental impairment, that slope is lower. I mean, your cognitive ceiling will be, for most people, or on average, lower. But the data have shown if we can give a child like this a cochlear implant, they can catch up with their peers. Right? So this is known data. And this is why we implant all of these children. But the question is, what about a child that's not deaf and has EDI? Here, you see that they're even lower in this example. They're even lower than a deaf child without EDI. But what if they're also now deaf? So the question is, are they going to catch up to where they would have been if they didn't have the hearing loss? Or maybe they'll be less. Maybe they'll even be lower than they would have. At that time, we just didn't know. So that was the study. So our hypothesis was that deaf children with early developmental impairment will benefit from cochlear implantation. This was based on just a little bit of representative data that we'd seen in our clinics. And I went to go meet with a statistician, O'Brien Smith. And my thought was, I want to publish the outcomes of these children that we had implanted as kind of a retrospective study. And he didn't know anything about hearing or cochlear implantation or anything, but he's a biostatistician. He's like, look, I mean, this is an unknown question. We don't have an answer, but we could know an answer if you did a prospective randomized controlled clinical trial. And what you should do is take all kids coming that have early developmental impairment and randomize them. And half will get a hearing aid and half will get a cochlear implant, and then assess how they do. And that seems kind of weird right now, right? But that's what he suggested, and that's what we do in medicine, right? We do prospective randomized controlled clinical trials to answer a question. And so we actually proposed that, and it ended up getting funded after. It didn't get funded the first time we submitted, but we submitted a revised grant, and it got funded as a randomized controlled clinical trial by the NIH. It was an R01 grant. It was my first R01 grant. But the problem is, by the time we had done this, it was 2 cycles. It was about 3 years later. And then things had already changed. So a lot of clinicians, audiologists, some doctors, just didn't feel comfortable randomizing patients because, every child's an individual, every family situation's unique. Many parents were now starting to want implantation because of the data showing that if, for children with normal cognitive status, they did so well. And there were financial incentives in that more and more insurances would cover it. And so a lot of surgeons just wanted to implant too. So at any rate, we couldn't do the study we had proposed. So we had to change it, and we were permitted to change it to a prospective longitudinal cohort study. And this got entered in the clinicaltrials.gov as an official clinical trial. And the inclusion criteria is that you have to, meet the audiometric criteria for implantation. You couldn't benefit from hearing aids, and you had to have a developmental age of under 60 months, so under 5 years. Exclusion criteria, you couldn't have any kind of progressive deteriorating medical condition or visual loss, because some of the assessment measures included how well children could respond to visual stimuli. So retinopathy of prematurity was an exclusion factor. You couldn't have autism or any kind of other inner ear issue. And at that time, I moved to Stanford. We set up a pediatric implant program there through their children's hospital. And so we ended up doing it at 2 sites, one in Stanford and one at Texas Children's. And it turned out that this was kind of a fortuitous move, because what happened was when we got to California, we realized there were pretty significant differences in insurance coverage between, if you compare Texas to California. And so if you didn't have developmental impairment, basically every insurance at that time was covering cochlear implantation. We really didn't have trouble getting insurance coverage for implants. But if you had early developmental impairment and you lived in Texas, then if you had the Texas form of Medicaid, which is called CHIP, they would fund cochlear implantation. And it was pretty much every child they would fund. What's interesting is if you lived in California and you had CCS, which is the California Medicaid, they would not fund a cochlear implant for the child with early developmental impairment. And for me, that was shocking, because you always think California's more liberal, they're gonna help kids and more than Texas, but no, they didn't. Now, I should say this has changed now, but at that time, it didn't. And then in both states, there were some insurances that would cover implants for children with developmental impairment and some that wouldn't. So basically what we did is we took all comers. For the most part, if they were covered, then the child ended up getting an implant. And if they weren't covered, then of course they didn't get an implant and they just stayed with hearing aids. And so we just followed them and compared the 2 groups. So how did assess them. So we did baseline assessments, and then we followed them at 1 year and at 2 years after implantation. And we had these 5 assessment measures. Cognition, we measured using the Mullen scales of early learning. And as I was talking to our psychologist, I know nothing about these kind of studies. These are performed by our speech-language pathologists and our psychologists in our groups. But that's a measure of cognition, or intelligence in a way. Adaptive behavior is the Vinland adaptive behavior scores, how well you get along in your environment. Language development, of course, PLS is a speech-language pathology instrument. And auditory development, we use the little ears. And then stress, parental child stress. It was actually it's called the Parenting Stress Index. It's a test, it's a survey that the parent fills out, but it assesses, it's basically a quality of life assessment for the child. If the parent's happy, the child's probably going to be happy too. So we said that if you have early developmental impairment, the definition is that both cognition and adaptive behavior are low. And this is based on what the definition of intellectual disability or mental retardation at that time we adapted. So the cognition has to be greater than 2 standard deviations below the mean. And adaptive behavior, we said, has to be 1 standard deviation below the mean in at least 2 different domain areas. And these are just some preliminary data plots showing that there's kind of a cluster of people below or to the left of the blue line under both domains that we had access to. And we did sample size calculations based on our preliminary data, and we decided that the 2 outcome variables that we were going to focus on was adaptive behavior, which is the Vinland visual receptive domain, and the PLS auditory comprehension score for language. And that's because they showed the most improvement with cochlear implantation over hearing aids in our preliminary data. And so when we did the sample size testing and ended up we would need probably 12 children per cohort, we doubled it because we figured, well, there's always kids we lose track of and don't follow up. And so we doubled it up to 24. And we also had multiple outcome variables. So this is a busy slide, but it kind of takes you through what we did here. And I guess I don't have a mouse, right, that I can point to anything. But anyway, I'll just talk you through it. At the top, so we enrolled 297 children in the study between the 2 hospitals, Children's and Baylor, Stanford Children's and Texas Children's Hospital. They all had a baseline assessment. And if they had normal cognition and normal adaptive behavior, this is on the far left, that's considered the normal group. All of these, I should say, are deaf, of course. And so that was 156. 18 never really followed up with us. 138 ended up getting a cochlear implant. And then we followed them for a couple years, and we lost 39 of them. So we ended up with 99 children that got cochlear implants that had normal cognitive status. That's cohort 1. And then cohort 2 and 3 came out of 66 children that had low cognition and low adaptive behavior, so they were considered to have the definition of EDI. And 37 had an implant, 29 stayed with hearing aids, and then we lost some to follow up, so it ended up cohort 2 mean they got a cochlear implant and they were delayed, was 32. And then cohort 3, there were 29 of them, they were delayed and they used hearing aids. And then there's this box of 75 children where they either had low adaptive behavior but normal cognition, or the other way, or vice versa. And so I didn't know what to do with them, so we just haven't studied them yet. The data's there. We need to look at it. And I'm not going to go through all the tables. There's a bunch of tables, of course, like any study like this. One of the key findings that you might expect is that there was a much higher prevalence of preterm infants in the children with early developmental impairment compared to those that didn't have early developmental impairment. And I'm going to skip that. So how do you analyze this data? So we're doing multiple repeated studies on children as they're developing. You know, it'd be nice if we got them at, right before the cochlear implant, exactly at 1 year and exactly at 2 years. afterwards. It doesn't work like that, unfortunately, in real life. Insurance, some insurances, fight about wanting to cover these follow-up examinations. And so by the time we get it, it might be several months off time. Some don't cover it at all. Some parents don't come back. Some move and then came back. And so anyway, we had a whole bunch of different times. So we chose a statistical approach called hierarchical linear modeling, which sounds crazy, but it's actually super easy to do, believe it or not, with modern software. And what it's nice for is it's really used a lot for kids. It's used for growth modeling. So anytime where you might be doing repeated measures as somebody's aging, and you don't know when you're going to be doing those, and some data points might be missing, it's a great way to do the statistics. So it accounts for random variations between how subjects kind of start their baselines. It accounts for variations in follow-up testing time, and if you have missing data, it's kind of permissive for that too. Okay, so we're going to skip that, and we're going to move on to the meat. So these are the actual results of the study, and it looks like a lot. It's not so bad. So let's look at the first row of plots, the top row. That's the Mullen scales of early learning, so that's cognition. And if you look at the x-axis, it's 0 to 60. That's their chronological age in months. And if you look at the y-axis, it's the developmental age in months. So it's just like those kind of hypothetical plots I showed you at the beginning. So in cohort 1, those are the deaf children that had normal cognition. And as they got older, their developmental age grew. The slope was 0.67. If it was 1, it would be perfect, right? They'd perfect development with age. This was 0.67 in these young children. And then if you looked at the cohort 2, so those are children with developmental delay or early developmental impairment that got a cochlear implant. And their slope is not as high. And if you look at the p-value, they're 0.0001, so it's statistically significantly lower. So they didn't do as well, and we wouldn't expect them to. But the real question is between cohort 2 and cohort 3. So the slopes look about the same. But when you do the hierarchical linear modeling, it's actually a significant p-value, and that just is a way to show you that you can't always just look at the raw data and just kind of a simple plot doesn't show you everything. So the linear modeling accounts for all of the variations between subjects. And so that's also statistically significant, p.0136. So basically, it meant that if you got the implant, your cognition developed faster than if you were using hearing aids. Vinland, adaptive behavior, same kind of thing. If you look between cohort 2 and cohort 3, actually here you can even see there's a slight difference in the slopes. And again, statistically significant. So cochlear implant helped adaptive behavior too. Preschool language scales. Cohort 2 versus cohort 3, quite similar, but still a slight statistical significant difference. Implant helped language development. And little ears, auditory, definite improvement with cochlear implants. So obviously much better hearing than with the hearing aids, which we knew they kind of already had failed. And then the last one is the parenting stress index. Now, you don't want stress to go up with time. You want stress to go down with time, right? So you can see 3 has the highest stress. So as the child didn't get an implant, there's more and more parental stress in the system as the child's getting older, where it's not as bad if you get the cochlear implant. So all of these are showing the same kind of thing, that if a child is born deaf and has early developmental impairment, at least as defined by what, the way we assessed it, cochlear implant gives you faster developmental rates than continued use of hearing aids. Limitations of this study is it was not randomized, and we only followed them for 2 years. So I don't know if the children with the hearing aids are going to end up kind of reaching the same cognitive ceiling as those that got the cochlear implants, but the children with the implants definitely improved faster. So the conclusion is that we think it should be, cochlear implantation should be considered for every child with severe to profound hearing loss, regardless of any coexisting cognitive impairments. And we want pediatricians to refer all children for cochlear implantation as early as possible. We noticed a lot of these children with multiple developmental delays didn't come to our clinic till they were a little bit older too. It'd be better if we can get them sooner. And then the final conclusion that's written there in the paper, if any of you have trouble getting insurances to approve implants, you can show them this paper because it's written right in the abstract, that it really shouldn't, cognition or cognitive status is not a litmus test for cochlear implantation coverage. So we didn't really, there's other things we want to think about. Those 75 kids we excluded from the study that either had low adaptive behavior or low cognition, but not both. I don't know. I need to find a resident or a trainee that wants to analyze all that data. The parent-child interactions and how do they predict outcome? I mean, this is such an important aspect. We also did, besides the parenting stress index, we recorded videos. We put the child and the parent in a room for 5 minutes and just had the video going. And this was in the SLP room, so there's a lot of toys on the ground. And we said, just play with your child. And they knew we were recording it. And then we could see, and we had coders that are psychologists that are experts in it, code the interactions. And it's interesting, some parents would just immediately pull out their phone and start doing something on their phone instead of playing with their kid. And then some would really get in there. And it'd be neat to know the outcomes of the different parenting strategies there. And so at any rate, there's just other considerations that we're also thinking about using this data for. I have so many people to acknowledge. I'm up here presenting, and I did the statistics, but the ideas behind this were not mine. They were the audiologists, the speech-language pathologists, the psychologists, and the statisticians that I worked with. And so you can see there's a huge number of people, and I'm sure I'm missing some, but I greatly appreciate all I've learned from my colleagues. Well, thank you very much, and I'm excited to move on with the rest of this panel. You see that cake there? That's a cochlear implant cake.
Yeah, I was looking at that cake. Very interesting cake. Thank you. Could we have the next slide set, please? Well, as that's getting ready, I want to thank you all for attending. I know there's so many good choices for you in this meeting and so many interesting papers and presentations to attend. But we appreciate your presence, and we hope that you're ready to be engaged and to be part of the discussion here. So, John, thank you so much for setting the stage for us with that wonderful presentation and for providing the context and the background that we need here. These kind of data are what we need to see more of, and it's what the results are what all of us who are clinical people in our hearts and in our guts know that our recipients with EDI, they do better. We know they do better, but it's always a challenge sort of demonstrating that, and it makes counseling these families about expectations very challenging, and appreciating that each child is unique and precious and may have a very different outcome. So such a diverse, heterogeneous group, and so it makes it's always been a challenge. And from my personal perspective, having been involved in cochlear implant care over the years, the very first children that we implanted had to be at least 2. They had to have no other known developmental delays or issues. And knowing that about 40% of children who have hearing loss do have diagnosed additional disabilities or issues and many of them undiagnosed, it's not a surprise that, the children that we see coming into our clinics have another diagnosis or multiple diagnoses, and may actually have even more as they grow older. So the evidence, the data is so important, but the decision to implant or not implant seems kind of binary, but we all know that there are many micro decisions that are made along the way, and in a number of different areas. So not just if you implant, but which device, when, how, what intervention, what counseling, those kind of things. So that's kind of the things that we hope to talk about a little bit more today. Before we get started, just for our knowledge and for everyone else here, if you're an audiologist in the audience, can you raise your hand and just look around? Oh, yay, lots of audiologists. Fantastic. If you're a speech-language pathologist, raise your hand. Wonderful. If you're an educator, any educators? Great. And how about therapists, psychologists, counselor, support person? Few as well. And do we have any physicians? Don't see many physicians. Okay. Oh, a few in the back. Awesome. Okay.
In the back, yeah.
Yeah. So John, we'll be relying on your perspective for some of those. As all of you appreciate, this hearing loss can put a child at risk for developmental and cognitive delay because of the auditory deprivation and the reduced auditory input. But many children also have other diagnosed and undiagnosed issues. So what we're going to do in the next hour or so is consider 3 cases that we have put together. And we'd like you to stay sort of mindful of a few concepts because it's not always an easy decision. And there are more and more things that get factored in, I think, as time goes on, as the inclusion criteria for implants gets a little bit broader, and now that we're seeing younger children where we may not recognize any other issues that they may have. So part of one of the things that we're as hearing professionals, communication professionals, is following evidence-based practices. And hearing healthcare, of course, is a science, and it's a practice that has to be supported by and delivered not just by our gut instincts or by the seat of our pants or by our intuition, but by evidence. And in the last 40 years, we've learned so much about deafness and about the auditory system, brain plasticity, child development, because of cochlear implants, right? It's been the ultimate clinical experiment about using technology to replace or reconstruct the amazing, intricate organ of hearing. So it's, we must continue really to continue to develop our practices and our treatment plans using our acquired knowledge and the growing body of evidence that results in optimal outcomes. So using evidence-based practice is a cornerstone of our professions, but when you have a population that presents many challenges, there may not be evidence available. So, and this then leads to clinical practice guidelines, right? So clinical practice guidelines, we have to aspire to making our pediatric healthcare management excellent in every corner of the country and in theory across the world. And the standard of care guidelines that have been developed around cochlear implantation have to apply to the small private clinic as well as to the larger university clinic and the hospital-based programs. Children with cochlear implants deserve the best that our experience and our knowledge can offer, and our professions require that we hold and update standards of practice that we are privileged to deliver. So, but how do we do this with such diverse populations when children don't fit the mold of the typical or the usual? And then this brings us to something that I've become increasingly aware of, co-design and co-treatment. Being in New Zealand and with a large indigenous population, any healthcare has to be delivered in the context of the recipient, in their family, their whānau, which means their extended family, their community. And so decisions about healthcare really have to reflect the culture and the beliefs of the family and their community. As we know, deafness really knows no economic, social, or cultural boundaries, so anyone can have deafness as part of their family. And so, our population is really the embodiment of diversity. So how do we recognize the needs and the strengths of each child within that context of their family and their community in an equitable manner? How do we interpret and apply evidence-based practices and clinical guidelines when we know that one size does not fit all. And then finally, and importantly, equity. As we know, deafness can engage. It can affect any family and their child, and giving that opportunity for a family to contribute in the way that they want to, without regard to health disparities, is really a challenge for us. So I'm going to hold these thoughts in your mind. I think that we practice on a day-to-day basis in busy clinics, and we see children that run the gamut in terms of what they present to us. But these sort of 4 principles, really, when we're looking about this very, very special population, I think we need to sort of hold these principles in the forefront of our minds. So I'm going to introduce our other panel members here, and many of you are already familiar with these folks. So in addition to myself, an audiologist, and John, a surgeon, Yvette Sages is a clinical psychologist from the University of Miami, Cochlear Implant program, and Deborah Schrader is a certified spoken language specialist and educator from the Cochlear Implant program at Keck, USC School of Medicine. So many years of experience up here on the stage, and combined with what you have out to what you bring, we should have a nice conversation. So have your polling app open, and I'm going to start with a quick review of our first case, and we'll have the polls come up in just a minute. So these 3 cases are all real-life children, and I think the scenarios may remind you of children that you've had in your own caseloads. There may not be correct answers to these questions that we're going to pose, but we're hoping it'll give us all some good food for thought. So the first case is a little girl, Olivia, who presents for cochlear implant assessment at 8 months of age. She has general developmental delays, neurological symptoms, including hypotonia, cerebral palsy, and of course, the diagnosis is CMV. So there was excellent presentation, and I think we're all very aware of CMV and all the things that come along with it. She has brain abnormalities that have been diagnosed through imaging, and an ABR has predicted a hearing loss profound in 1 year and moderate to severe in the other. However, cochlear structures are intact. So there's her CT scan, and there's behavioral and physiologic evidence of the results of the CMV infection. So 8 months of age, she and her family come into the clinic. I'll skip over this. I think we all have a good understanding of all that accompanies CMV. And here's that audiogram. So a profound loss in the right ear, a moderate to severe sensorineural hearing loss in the left with evidence of progression. And so the families coming in, they're eager to learn, want to know more about what the opportunities are for their daughter. So let's go ahead and have the first poll question. Of course, I know many of you have probably other questions or coming up in your mind about what information you would want to know about that child and the family, but just as your first response, what would you consider for this child the top management priority as you're counseling them about the possibility of cochlear implantation? So go ahead and vote. I don't know if our panel's voting as well. Yeah, that is. Okay, let's see what your opinions are. Interesting. Oh, and some people still voting. So, really interesting, right? I think we all as professionals know early implantation is what it's all about. But people are maybe changing their minds, still adding. Family readiness, also very important. And I think we could all agree that all 3 of these issues are very important. But having to decide on your first choice, early implantation. So that's really interesting to me. Yvette, I kind of want to turn it over to you because I think some of these other issues, and John, your question, my question to you is about these other health management issues. But Yvette, let's go with you first. Family readiness, what did you vote for?
What did I vote for? I wanted an option for A, B, and C.
Yeah.
But since I wasn't given an all option, I think as a psychologist, my role would be B, so making sure the family is ready. However, obviously, right, I think this is the hard part when we work with children with multiple disabilities, that my goal is knowing that early intervention is going to give them the best opportunity, and the earlier we get them implanted, their outcomes are going to be better regardless of their intellectual capacity or their overall development. But as part of that process, I would use counseling to make sure I get them ready if they are not. What we know from just looking at the psychological literature is just if they're not ready, they're not going to follow through the recommendations, and then they're not going to go ahead and use the implant to the capacity that it can be used for assistance with listening and spoken language. So I would vote, if I had to pick one, which I really didn't want to, I would still stick with B.
It's interesting how, as you're speaking, the numbers are changing a bit. So, John, management of other health issues. We've all seen those children that, especially if we're looking at children who are younger, may have even some undiagnosed health issues. How, as a surgeon, do you approach the priorities?
Yeah, my part is the least of this child's issues. For me, if the MRI shows that the inner ear is fine, then it's just a matter of can they tolerate the anesthesia? And anesthesiology can do an evaluation for that, or if they have heart issues, cardiac issues, we need to get that checked. But that's not so much a problem. The surgery is an hour or less. It's a very light dose of anesthetic. Can't say I've ever done it on an awake child, but certainly I've done it on awake adults when they can't tolerate anesthesia. So I would say the risk of doing an implant medically is very, very low.
Yeah. And interestingly, sometimes we do have questions. That is the utmost concern of families, right, is those surgical risks. Okay, let's look at the next question. Well, do you have okay, Deborah, sorry, you wanted to comment?
No, I just wanted to add that I wanted a D option too.
Yeah.
And I wanted an option that really said care coordination, because I think of hearing loss as a chronic health condition. And I think about the families need to be able to manage all of the health, all of the related appointments, but the important role that the early interventionist holds too, and the family, in helping the family understand the influence of hearing loss on overall global development. So I wanted a D option, care coordination, because I think it's really important that we manage the child's care from a holistic point of view.
Yeah, and I think that begs the question too. So many of our centers do not have that role, and I think, that's really been highlighted in this meeting, how important that is, having that person or that team approach where you can address those management issues.
Yeah, just one question is, can you do I know you can do a surgery to put early cochlear implantation, but would a team do that without the family being ready? That seems to be a prerequisite to early cochlear implantation.
Anybody out there want to say anything about that? We used to have questionnaires that were really an important part of the decision-making process, where we are actually, it may not have been, some of it might have been information that was gathered from the family, but then the team had their own opinion, and I've been in cochlear implant team meetings where there was actually a form that was filled out where a patient was graded, if you will, on what their likelihood for success was, and it was done in a way to help prepare and to counsel. I think that's gone by the wayside a little bit in my experience, but is that something? Great, okay.
I think that sometimes we wind up bullying families because the surgeon has said this child's ready, the speech pathologist has said it, the audiologist, early intervention, and we're really not taking into consideration that that parent is really ready. They showed up to the appointment, but we really bully along sometimes. And if the child also has other cardiac problems or they have other children with medical problems, we really need to decide, well, if we wait 3 months, what's better for this family long term?
So one thing I think it's a bigger issue is that oftentimes these children are getting to us later. So I think that's where the problem more comes in of equity, is that we should still be using the same guidelines of like 1, 2, 3, and hearing should still be one of those primary kind of issues that are being addressed up front that are not. So, you know, if we have a family who's following those Joint Commission guidelines and getting to us as early as 1 month, we still have that opportunity to kind of get them ready to be an implant versus showing up at 8 months where they might not be ready, and then we're kind of trying to balance the importance and that we know early implantation, but they might just be hearing this for the first time. So I think we all need to do a better job, pediatricians, you know, birthing hospitals, to make sure that yes, this child might have other health conditions, but we should still be talking about hearing at that same time in addition to everything else that's going on.
Thanks. All right, I'm going to move us along in the interest of time. The next question, so this was a child with an asymmetric loss, evidence of progression, and now we're making a recommendation about cochlear implantation. So a decision has been made, yes, we want to implant. Is it a bilateral simultaneous? Is it a unilateral CI with a hearing aid fitting? So bimodal management of a child under 1 year of age. Those audiologists out there who do that kind of work, you might have a strong opinion about that. Or do we just leave it up to the parents? So what are your thoughts on that one? All right, let's see our answer. You know, this is exactly what I hoped would happen, that there wouldn't be really consensus on some of these questions because they are so uniquely related to the family and their situation. From the audiologist standpoint, I know that, you know, sequential surgeries are sometimes the better option because it gives us an opportunity to see how the child's going to respond, how the family's going to be able to engage and support, and then have more confidence when they come to make a decision about the second side. However, from a therapist's point of view, I've had therapists who say, no, please, just both ears at once. Let's get on hearing with binaural hearing and see how the child, you know, make the most of both ears, especially when we can predict probably that there will be a sequential implant. So what does the panel think on this one?
I would go bilateral simultaneous. And I think sometimes if it's a progressive loss, obviously, and I think if obviously this is a team decision, so it would be something where this one probably in Miami would have a lot of debate. But, you know, coming together and really just making sure we follow the family's need. Obviously, if they want minimal surgical intervention, that's also something to consider. So it really is, even though maybe I would think that bilateral would be the best option, it likely might even end up being unilateral with bimodal fitting.
Deborah?
No, likewise, my thought initially was bilateral simultaneous. I certainly want to hear and value and honor the parent's voice, and I want to understand the parent's feelings, but I think that one surgery, bilateral simultaneous, is probably going to give that child better access to listening and spoken language.
Yeah. Any thoughts, John?
Hey, how old was this child again?
8 months old.
Oh, very young, yeah. So you don't really know how cognitively impaired the child is. Yeah, I'd do bilateral simultaneous then too. Yeah, you know, but it's a good point because they get older and maybe they're pretty impaired, and maybe one is enough on a child like that.
Any thoughts from the audience? All right, let's move on to the next question then in this poll. Okay, now we're talking about mapping and device programming. So, you know, I think we maybe dismissed the first one, bimodal integration. You know, that's a challenging thing to do with, I think, an adult, much less a young child, not to mention a baby. But given that we may not have, and actually, maybe I'll move on to the next poll. Let's skip this polling question, see what the next one is. Yeah, let's focus on this, I think. So the recommendations for communication mode therapy approach, recognizing the developmental and cognitive delays of the child. So again, this is a very personal and probably situation-specific question, and it may be influenced by where you are in the country and what kind of philosophy your school system and your program holds. But please vote. Listening and spoken language.
Oh, okay.
So total communication approach, listening and spoken language, kind of a traditional approach, or a combination, seeing where the child, seeing a kind of a wait and see approach, right? And this is where our evidence sometimes is lacking. All right, let's see our results on this one. Interesting. I'm a bit surprised, but I'm a bit interested that we've got such a combination here, especially, you know, this is an audience of active clinicians and all across the domain of areas, so interesting. Deborah, I'm going to turn to you first. Any thoughts on this?
That's a tough one.
Controversial here.
I know. If the assumption is that the baby has bilateral simultaneous surgery at approximately 8 to 9 months of age, I think based on the baby's developmental profile, the fact that the baby has cerebral palsy, that my tendency is that I would absolutely want to emphasize listening and spoken language, but I would want to make sure that, thinking about Donna Sorkin's talk this morning, the language of the home and language nutrition, that baby had access to information before the surgery and during those early developmental opportunities to build joint attention, turn taking, that I would probably support listening and spoken language with the use of intentional signs to promote taking turns talking, just to see, and to monitor child progress with vigor at that point in time.
Yeah. Any other comments from the audience? Yes.
I'd want to do an AAC evaluation. I have a lot of patients who have cerebral palsy who are also implanted, and having that other means of communication, especially because AAC can work with the family's natural language and really support that. And then if the child progresses with their spoken language, that's great, but if they don't, they have another means of expression.
Just tagging onto that, but at 8 months of age, they may not have all the prerequisites for looking at AAC, other than you're going to want to work on the turn taking and the cause and effect kind of things. So if that's the AAC piece, I definitely support that. Personally, I'm going to try LSL with natural gestures first, until I see that it's not working. Because if this child has cerebral palsy or motor problems of some kind, that ability to sign is going to be potentially impaired. And this is the spoken language, assuming that's the language of the parents, that's going to be the easiest place for them to start. And turn taking, this idea of back and forth and joint attention is all fits under the LSL umbrella too. It doesn't have to be part of a signing language. It's part of the LSL piece too.
Thank you. Yes?
So I picked A, and I think that when I think of the total communication approach, it's whatever the child needs and whatever the family is able to supply. I think that, some of the comments I've been hearing, what you guys are talking about a lot is expressive, right? We need to also think about the fact that this kid maybe receptively is not going to understand or have complete access for a while. And so I believe in kids that are deaf or hard of hearing that having access to both is not going to harm. And if we're able to give them visual access to a word or a sound that they're maybe not able to hear, that I'd rather do that than just be unimodal.
Thank you. Great, one more?
Yes, just to piggyback on what she just said, also the fact that there are cysts in the temporal, I think it's the same child that we're talking about, that there were like cysts in the temporal lobe. We don't know how that is going to impact comprehension. And so I would also want to emphasize multimodal communication with an emphasis on listening, but opening to all modalities so that we can learn how the child is progressing.
There's also a discrepancy in terminology here. So when you look at total communication approach, we all might have a very different idea of what total communication is. And so from my perspective, maybe total communication would be an emphasis on listening and spoken language strategies, emphasis on auditory skill development, but at the same time, maybe that child who is only 8 months, that's the case study, right? The child at 8 months of age, we don't know expressively what they are going to utilize as their primary language modality. However, these skills do not have to live in isolation. They're not in a vacuum. We can work on listening and spoken language skills. We can give that child access to other supports such as augmentative communication, and we can build their skill levels as they are growing up.
Yeah, and I think what's been interesting is, like, listening is that we are making very strong recommendations and opinions for an 8-month-old. And when in general, when you have an infant, you're focusing on play and natural interactions with the family. And so when I'm thinking about it, I think my natural way would think that a lot of the principles, let's say, of listening and spoken language are about that. It's about building upon that parent and child relationship. And yes, that includes access, but of course with close monitoring. And, a lot of kids by 1 year old, even normal hearing children, sometimes are delayed. And so I think sometimes, right, us as professionals and our own biases, we're very quick to jump to something else without giving these children, particularly those with developmental issues, time. And time is a piece as long as they're getting the right intervention. And I think we have to just monitor more closely, but still make sure that the family's decision is there. A lot of these families, let's say even in the Miami location, while maybe I do think that they could benefit from some visual communication, the likelihood of them learning it to a level that they could teach their child sometimes is very difficult. They can't even, maybe even learn English, and we're focusing on Spanish. So I think a lot of these things, we have to have those discussions with the family and sometimes allow that to kind of guide what we're gonna say, even though we might come in with some of our biases along the way.
Great. We're going to move along. We're going to run out of time to do both of our next two cases. John, this next case is yours.
Run the next one?
Yeah.
Okay. These are great discussions. All right, Jose, patient of mine, 2.5-year-old, 2.5-year-old kid. He was a 28-week-old premature infant, spent 6 months in the neonatal ICU. He had a trach tube, but it was now removed. He still has a G tube for feeding, but he can eat some food orally now. At 6 months, his ABR showed bilateral mild to moderate severe, bilateral to moderate sensorineural hearing loss. At 18 months, moderate to severe, and his behavioral audiogram now shows severe sensorineural hearing loss. Retinopathy or prematurity in the left eye. MRI is normal. Parents are full-time farm workers in California Central Valley. Spanish is the primary language. The child has hearing aids, but he doesn't really use them. He has pre-verbal vocalizations consistent or to convey communication intent. Yeah, I think I had a different, basically he's just kind of grunting or moaning kind of sounds. I don't know what that is. IFSASP. Did you change that? I know I didn't write that one.
Intervention program.
Okay. So he's in a deaf and hard of hearing sign language communication group. Okay. No, I didn't write that one. So his cognitive scores, 15th percentile, motor scores, 18th percentile. So a little bit below normal. Not horribly, but a little bit below normal range. But his adaptive behavior quite low for 2nd percentile. Oh, these weren't the question. How come they didn't?
I think some of the considerations, but why don't we have the first?
Do we have the polls?
Yeah.
Is this the first one?
Yeah.
Okay. So if they want cochlear implantation, what would be your approach? The profile. He was 2.5 years old in a deaf, hard of hearing preschool, and doesn't wear his hearing aids. Okay, should we see what the results are looking like? So I guess nobody wants just unilateral. Oh, one person wants just unilateral. Good. Holly, from an audiological perspective, what do you think?
Yeah. I think that years ago, we probably would have said unilateral CI and said, let's see how this family adapts, how they cope. Years ago. But I think in our current thinking, we want to give every child every opportunity, and then make sure that we have built the bridge to help them have the resources and support that they need for habilitation, which isn't easy. We have tools, we have data logging, we have peer support, we have family, the indices and questionnaires that we can do, and additional counseling, I think. And we know that device usage is strongly related to outcomes. So I'm thinking that that's part of the question is this family going to be at risk for not putting the device on their child? And if that was the case, you start with one and see how it goes and then go to the second. But I would hope that we would go with the bilateral simultaneous, even knowing that they would need additional supports.
Mm-hmm. Debbie?
No, I'd agree with what Holly just said.
Okay, good. Any other? Okay, let's move to the next question. So what habilitative management do you recommend? So cochlear implant with a weekly listening spoken language services, continue with a hearing aid and transition to a TC program, or give up on the hearing aids and just go to a sign language program. Parents are migrant farm workers in the Central Valley. Spanish is a language at home. All right, let's see what people say. Oh, wow, big time, okay.
Yeah, I think this really reflects
That's
some
great.
of the changes that we've, I think we've all seen and probably put into support ourselves, into place ourselves over the last few years. You know, when you have a child who's had hearing, has previous experience with hearing, that's always, you know, a good indicator. You know, they've got that some exposure to sound that's going to help them interpret the new signal. And to focus on an auditory approach with that family, I think would be a good place to start. Yeah.
Any other?
And I also think you have to think about the child's school placement, the school program, and how you're going to coordinate care among service providers so there's consistency, and so that the child has an opportunity to use his hearing across all environments and is coached to use his hearing across all environments.
Yeah, this has really changed, because I think it wouldn't have been but maybe 5-10 years ago. I think B and C would have had a lot more. That's great. Okay, let's go to the next question. If the parents spoke English as their primary language, would your recommendation change? And I'm guessing that's probably no. Since everybody pretty much had the same one to begin with. So let's move on to the next question here, just in a matter of time. The father was an attorney, the mother was a pediatrician. Well, no. So this is a much better family situation we're talking about here, right? I had actually expected quite a few of you to talk about just going to sign language, which is what I've seen at many places. This is amazing. Maybe this is a particular group here.
Yeah, you know, this audience may not be completely reflection of what
What's
practice
happening.
is. Yeah, possible.
Okay, so I think that might
Yep,
be
I've got
this
one more.
case.
Okay, 5 minutes, quick one here. Okay. So the next one is, a child, preterm baby, low birth weight, intensive perinatal care, long time in the NICU, with lots of the known outcomes that happen with a NICU visit that last a long time. The ABR suggests OAE present in the right ear, cochlear nerve deficiency on that right ear. So some outer hair cell function, cochlear nerve deficiency. Other ear looks pretty good. So a normal an imaging on the left, cochlear nerve deficiency on the right. And this was from a case that we had in Carolina that had a really interesting outcome. So the child, you know, the audiometrics show profound deafness bilaterally, but we know we have a cochlear nerve deficiency, some unusual anatomy on one ear. And so you might guess what the question, lots of considerations here, but let's have the first polling question. Oops, next one. Recommendation for surgery. Bilateral simultaneous, unilateral CI, do not implant the C and D ear, or sequential CI after mapping stabilized on the first ear.
C and D is the one without the nerve?
Right.
Okay.
Yeah. A wisp of a nerve, maybe, a little bit of evidence of nerve, but what we're calling now cochlear nerve deficiency. And what are our results? Yeah, I think there's been some interesting presentations in this conference. Yesterday, the CT imaging and modeling, where the surgeon actually practiced an insertion on the Stapes-Gusher child. I don't know if you saw that presentation, and had a practice to actually insert the device several times before they got to the OR. And I think we've all had these situations of what some people have called the unicorn, the child that you didn't expect because based on imaging it didn't look like there was a good nerve survival, a good nerve connection. The bridge was out in the internal auditory canal, and those kids still end up with some useful hearing that can be mapped. I think we've learned some new strategies on how to manage that. And for me as an audiologist, it gets into a whole nother discussion about how we should be, continue to be experts in managing and mapping children who have cochlear nerve or cochlear malformations, not relying on some of our just objective measures, but really looking at behavioral measures and taking that extra time and using our knowledge of how cochlear implants work to appropriately implant these children, or program these children.
I know we're running out of time. I would be more towards the B category. I think, this is not necessarily an inner ear malformation, but either little or no auditory nerve. A cochlear implant, even if you can get it in and program it, whatever, it's not going to be as good as if there's a normal nerve. If the child had this picture on both ears, actually bilateral simultaneous might make more sense, because you don't know which one's going to work better. But in this case, if you implant the one with the big, fat, juicy auditory nerve, it's going to work really well. And it's kind of like, would you put a hearing aid on one ear if the word recognition was 30%? Probably not, right?
All right, I don't see anyone from the audience, so let's go to the next poll question. Device choice. So when it comes to these kinds of cases, as probably this might be something that impacts audiology, but I think it's also something for habilitationists, in terms of what tools and techniques are available to work with these kids. Do we go with the surgeon's choice? Do we go with a device that we have more confidence in using the objective measures? Or do we just let the parents choose which of the manufacturers they want to use? All right, and the answers are, now it's fair to say we don't have many surgeons in the audience probably, so we know that. Very interesting. Any comments?
From a surgical perspective, they're all equally easy to put in, and it really doesn't matter, I think, to most surgeons what we use.
Great. I see someone coming up. Yep.
Questions are making a really good case for why we need to work as a team.
Good point. Thanks, Ellen.
Questions get answered that way.
Yes. Thank you, Ellen. Okay, we've got two more quick questions and we're wrapping up really fast. Amy's giving me wide eyes. All right, next question. Therapy. So this is an important question for these kids. Do you go with a typical binaural CI approach? You're going to have different skill sets from each ear because of the cochlear, because of the different auditory capacity. Unilateral therapy, work on each ear separately and then also together. So I guess it's really a kind of a binary thing. You just go with a typical binaural approach, or do you do some individual ear therapy for these kids? And what's the audience feeling here? Yeah. That's interesting, I think. Deb, do you have any comments on this?
To be perfectly honest, I want more data before I answer that. I want to see what happens at activation. I want to see what happens at that 2-week post. I just want more information. I felt that way about one of the questions I answered previously. It's just I want, and again, it goes back to your point a minute ago, it's what members of the team can provide, because I think as a team we're making a recommendation as to what the therapy approach and goals for intervention would be.
Yeah. Yeah, I think our experiences with our sequential kids taught us a lot. That we really want to go for binaural integration. And so I think we've really had a good learning curve with this, I think. All right, the last question. Are they waiting? And this is really more of an audiology focused question probably, but when we're relying on, if we know that we need to turn off some electrodes because of the cochlear nerve deficiency or the cochlear malformation, when do you do it? Do you wait until you can get some good behavioral responses from the child? Do you rely on your objective measures? Or do you keep a full array until the child gets a little bit older and you can make some decisions and make some changes in mapping then? So that's really more of an audiology-focused question, honest for my interest in a lot of ways. And what are our answers here? And maybe no one voted, I don't know. Kind of a wait-and-see approach. All right, well, I think we've run out of time, and I want to thank the panel for their input and the audience also. I think this has been a great exercise and really demonstrates how many different schools of thought there are in managing children with additional needs, and that we have a lot to learn, and more evidence is really important, I think. Yeah. Thank you all.